Welcome to Darshan's Medical Education. Today, we explore one of the most important devices in modern cardiology, the cardiac pacemaker. A pacemaker is a small electronic device, typically weighing just 20 to 50 grams, that is implanted beneath the skin of the chest. Its purpose is straightforward yet life-saving. It delivers precisely timed electrical impulses to the heart muscle, ensuring that the heart beats at an adequate rate and rhythm. Every pacemaker consists of two main components. First, the pulse generator, a titanium-encased unit containing the battery and microprocessor. Second, one or more leads, thin, insulated wires that carry electrical signals between the generator and the heart chambers. So, what conditions does a pacemaker treat? The heart has its own natural pacemaker, the sinoatrial node, which generates electrical impulses that travel through the conduction system to coordinate each heartbeat. When this system fails, a pacemaker steps in. The most common conditions requiring pacemaker implantation include sinus node dysfunction, also called sick sinus syndrome, where the heart's natural pacemaker fires too slowly or irregularly. Atrioventricular block, where electrical signals are delayed or completely blocked between the atria and ventricles. This ranges from first-degree block to complete or third-degree heart block. Bradycardia-tachycardia syndrome, where the heart alternates between dangerously slow and fast rhythms. And chronotropic incompetence, where the heart cannot increase its rate appropriately during physical activity. The decision to implant a pacemaker is guided by established clinical guidelines from the American College of Cardiology, the American Heart Association, and the European Society of Cardiology. Class 1 indications, where pacing is clearly beneficial, include symptomatic sinus bradycardia, complete third-degree atrioventricular block with or without symptoms, symptomatic second-degree AV block, alternating bundle branch block, and chronotropic incompetence causing symptoms. Class 2 indications, where evidence supports pacing, but with some clinical judgment required, include asymptomatic Mobitz type 2 block with a wide QRS complex, sinus bradycardia with heart rate below 40 beats per minute without clear symptom correlation, and certain patients with neurocardiogenic syncope or hypersensitive carotid sinus syndrome. The 2021 ESC guidelines also emphasize pacing for patients over 40 years with recurrent reflex syncope and documented asystolic pauses greater than 3 seconds. Equally important is knowing when not to implant a pacemaker. Pacemaker implantation is contraindicated in the following situations: asymptomatic sinus bradycardia or asymptomatic first-degree AV block. AV block that is expected to resolve, such as from drug toxicity, Lyme disease, or transient increases in vagal tone. Bradycardia during sleep without daytime symptoms. And symptoms suggestive of bradycardia that are documented to occur even without actual bradycardia. In essence, reversible causes must always be identified and treated before considering permanent pacing. The implantation procedure is typically performed under local anesthesia with conscious sedation and usually takes 1 to 2 hours. Step 1. Venous access. The surgeon makes a small incision below the clavicle and accesses the subclavian or axillary vein using the Seldinger technique, guided by fluoroscopy. Step 2. Lead placement. 1 or 2 leads are advanced through the vein into the superior vena cava, through the right atrium, and positioned in the right ventricle, typically at the apex or the septum. In dual-chamber systems, a second lead is anchored in the right atrial appendage. Step 3. Creating the generator pocket. A subcutaneous pocket is fashioned in the pectoral region to house the pulse generator. Step 4. Testing. The leads are connected to the generator, and electrical parameters are measured, including sensing thresholds, pacing thresholds, and lead impedance, to confirm proper function. Finally, the incision is closed, and the device is programmed to the patient's specific needs. As with any invasive procedure, pacemaker implantation carries potential risks. Early complications include pneumothorax, where air enters the pleural space during venous access. Lead displacement, occurring in approximately 2 to 3% of cases within the first few weeks. Pocket hematoma, a collection of blood at the generator site. And rarely, cardiac perforation leading to pericardial effusion or tamponade. Late complications include device infection, which may require complete system extraction, lead fracture or insulation failure, and venous thrombosis of the subclavian vein. Fortunately, major complications occur in fewer than 5% of procedures when performed by experienced operators. The benefits of pacemaker implantation are substantial and well documented. Patients experience significant relief from symptoms such as dizziness, fatigue, syncope, and exercise intolerance. Quality of life improves dramatically, with most patients returning to normal daily activities within days of the procedure. For patients with complete heart block, pacing provides a clear survival benefit. Cardiac resynchronization therapy in heart failure patients has been shown to reduce mortality by up to 36% in landmark trials such as CARE-HF. Modern pacemakers last 10 to 15 years, are MRI compatible, and can be monitored remotely, making long-term management convenient and effective. Thank you for watching. If you found this video helpful, please subscribe to Darshan's Medical Education for more clinical content. Stay curious, stay informed.